The following podcast is part of a certified educational activity titled Leveling the Playing Field for All Patients with Severe Asthma, Directing New Treatment Approaches at the Airway Epithelium. Access the entire activity and complete the post-test at peerview.com/TCG860. Downloadable slides and practice aids are also available.
Hello, welcome to this educational activity called Leveling the Playing Field for All Patients with Severe Asthma, Directing New Treatment Approaches at the Airway Epithelium. I'm Juan Carlos Cont'd. I'm an allergist immunologist at the University of South Florida. I'm joined by Dr. Jeffrey Chuck, Professor of Medicine and Pulmonologist at Yale University. So to give you the agenda for this presentation, titled How I Think and How I Treat, a case-based demonstration and instruction of approaches to the management of severe asthma. Number one, reaching for a broader target, the importance of the airway epithelium, and two, choosing therapeutic options for patients with severe asthma as the treatment landscape evolves. So let's start with reaching for a broader target, the importance of the airway epithelium. Let's talk about severe uncontrolled asthma and give you some epidemiologic data on it. Severe uncontrolled asthma, as clinicians know, has a great impact on quality of life due to excessive symptoms, frequent life-threatening exacerbations, and is mostly associated with increased comorbidity burden and greater pharmacologic treatment requirements. More than half of patients with severe asthma have 3 or more exacerbations per year as disease severity worsens, which contrasts with 5% of patients with mild asthma that have this burden, and 13% of patients with moderate asthma. 5 to 10% of patients with asthma approximately are considered to have severe asthma, and globally, around 2.5 million patients with severe asthma were uncontrolled or eligible for biologic therapy. In the US, there are about 1 million such patients. A significant number of patients remain uncontrolled despite treatment. Let's review some terminology as we have been using the terms uncontrolled and severe asthma. Let's start with severe asthma. Asthma, which is asthma that is uncontrolled despite maximal optimized therapy, which means high dose inhaled corticosteroids and a long acting beta 2 agonist and treatment of contributory factors, or it's asthma that worsens with such high dose treatment is decreased. In contrast, we have uncontrolled asthma, which can happen at any level of severity. Mild, moderate, or severe asthmatic patients may have uncontrolled asthma, which is defined as frequent symptoms and or flare-ups or exacerbations. Difficult to treat asthma, in contrast, refers to severe asthma, so asthma uncontrolled despite prescribing medium or high dose control of therapy. But in addition, there are contributory factors that might include an incorrect diagnosis of asthma, or incorrect inhaler technique, or poor adherence to therapy, or treatment of the lack of treatment or incomplete treatment of comorbidities that may accentuate asthma-related symptoms. Let's review some of the information that we got from the American Thoracic Society, European Respiratory Society Task Force on Severe Asthma from 2014. Severe asthma is asthma that requires treatment with guideline-suggested medications for GINA steps 4 and 5, which is high-dose inhaled corticosteroids and another controller therapy for the prior year, or the use of systemic corticosteroids for more than half of the previous year to prevent it from becoming uncontrolled, or that it remains uncontrolled despite this therapy. Characteristics of poor asthma control include 2 or more oral corticosteroid requiring exacerbations in the last year, or serious exacerbations, which means 1 or more hospitalizations for asthma, or ICU stays or mechanical ventilation in the previous year, or persistent airflow limitation, defined as an FEV1 less than 80% predicted. What is the evaluation for severe asthma? First of all, is a confirmation of the asthma diagnosis, and this is done through a thorough physical and history taking and physical exam, in addition to spirometry showing reversibility and X-ray evaluation, addressing medication adherence and proper technique. Then it's evaluating whether or not this is severe asthma. And this is done with full PFTs, which means a plethysmography with DLCO measurement, methacholine challenge for airway hyperresponsiveness, and FeNO measurement wherever available. Other biomarkers include blood eosinophils and total serum IgE. In terms of imaging, the next step is high resolution CT scan of the lungs and the treatment options beyond those specified by guidelines. Then is the issue of what is contributing to the asthma symptoms. Other issues to further evaluate include assessing and managing comorbidities. Some of these, and we will review them in the next few slides, include atopic conditions, allergic bronchopulmonary aspergillosis, chronic sinusitis, COPD, GERD, vocal cord dysfunction, obstructive sleep apnea, obesity, and depression, among others. Then it involves referring to a specialty center where additional workup for phenotyping and comorbidities is involved, and potentially novel investigational interventions. Then is the issue of treating severe asthma or treating difficult to treat asthma, and what is the difference? So again, symptoms might involve the cardinal symptoms of asthma, which include shortness of breath, coughing, wheezing, and chest tightness, especially those that are not controlled by high-dose inhaled therapy. First, it's symptoms due to asthma. So address adherence and inhaler technique. But when those are addressed and symptoms remain and it's due to asthma process, then these symptoms are due to airway inflammation or airflow obstruction. When it's difficult to treat asthma, these symptoms might be due to an alternate diagnosis or exacerbated by a frequent comorbidity of asthma. And these need to be addressed themselves. Some of these include expanding on the prior slide, dysfunctional breathing, vocal cord dysfunction, laryngeal obstruction, GERD, anxiety, and other psychiatric conditions, deconditioning, obesity, obstructive sleep apnea, excessive dynamic airway collapse, tracheobronchomalacia, COPD, bronchiectasis, and heart failure, among others. Then it's the issue of addressing modifiable causes of asthma control. Two main issues are non-adherence, which is very common across all severities of asthma. It's a frequent reason for difficult to treat asthma in adults and children. This must be a priority for all clinicians. When non-adherence is identified, clinicians should have an empathetic discussion and identify and address potential barriers to adherence. Similarly important is incorrect inhaler technique, which is associated with poor asthma control and frequent ED visits. Clinicians should observe patients' inhaler techniques and compare with a device-specific checklist. Errors should be corrected and techniques should be rechecked frequently during outpatient follow-up. Asthma is a heterogeneous disease, which means that patients may respond differently to different treatments. All of these, there is a convergence of different pathophysiologic mechanisms that lead to the reversible airway obstruction and airway hyperresponsiveness that are characteristic of asthma. There are different phenotypes, which is the outward manifestation of a disease, and there are different driving endotypes, molecular mechanisms that lead to such phenotypes. The current concepts on the different heterogeneous phenotypes of asthma is that several inflammatory subtypes of asthma are involved. In terms of airway inflammation, there are different biomarkers and different ways of getting these biomarkers that are accessible to phenotype asthma. These include sputum, BAL, bronchial biopsies, FeNO, blood eosinophils, and allergic sensitization. In terms of phenotype, a way to categorize them by inflammatory subtype is eosinophilic, which may be due to allergic and non-allergic conditions. Neutrophilic on the other end of the spectrum, Paucigranulocytic, which means the absence of granulocytic inflammation, and then mixed eosinophilic and neutrophilic. You can see that these different phenotypes fall into different ranges of the spectrum of endotypes. On one end, there being type 2 inflammation driven asthma or type 2 high, On the other extreme is non-type 2 or T2 low inflammatory types. Let's find out some more about these different subtypes of inflammation driving asthma. For T2 high, again, this might be driven by allergic inflammation or non-allergic but eosinophilic inflammation. The biomarkers and cytokines characteristic of this one are increased blood eosinophils, increased BAL and sputum eosinophils, increased FeNO or exhaled nitric oxide, increased total serum IgE, aeroallergen sensitization, and allergic conditions with clinical relevance, and the presence of the main cytokines driving type 2 inflammation, which include interleukins 4, 5, and 13. For T2 low asthma, many of these are neutrophil high, which are characterized by increased BAL and sputum neutrophils, increased expression of interferon gamma, interleukin 1 beta, 6, 8, and 17, and tumor necrosis factor alpha. Also, there is Paucigranulocytic, the abstinence of granulocytic inflammation in T2 low asthma, which is a normal BAL, sputum neutrophils, and eosinophils. And there is the uncoupling of airway obstruction from airway inflammation. And then there is a mixed granulocytic, which includes a mix of eosinophils and neutrophils in BAL and sputum. Let's find out some more about T2 high asthma. It is most often associated with immediate IgE-mediated allergic reactions, eosinophilic inflammation, which again may come with or without concomitant allergies, and it's typically characterized by responsiveness of corticosteroid therapy. In contrast, T2 low asthma, which is often neutrophilic, there is a predominance of neutrophils in sputum and BAL. One threshold for these is more than 40%. It is associated with oxidative stress, often chronic infection, smoking, or a high-fat diet. In general, it is associated with a poor response to corticosteroids and higher associations with fixed airflow obstruction. In this T2 low asthma, the airway epithelial cells produce cytokines that stimulate Th17 cells, which drive, attract, and stimulate neutrophils. T helper 1 cells are stimulated by innate immune stimuli to drive neutrophilic inflammation as well. In many cases, the airway microbiology is at play in driving this kind of neutrophilic inflammation with a greater frequency of pathogenic taxa at high relative abundance. For the type of T2 low asthma that does not have inflammation or Paucigranulocytic, there is, as the name implies, no evidence of increased eosinophils or neutrophils. Considered to be non or low inflammatory. There's less known about this type of asthma. Airflow limitation results of structural changes in airway remodeling, and there is uncoupling from airway inflammation. There is evidence of collagen deposition and airway smooth muscle proliferation, just as in other cases of asthma, but in the absence of inflammation, there is persistent airway hyperresponsiveness, and in most cases, it's thought to be steroid insensitive. You can see in the Venn diagram to the right that there is an overlap between the 3 main characteristics of T2 high phenotypes, which are allergic sensitization, blood eosinophils greater than 300 cells per microliter, and FeNO greater than 30 parts per billion. Not always there is full overlap in these 3 characteristics, but often there is. And outside of this Venn diagram, there is the T2 low phenotype, which constitutes another proportion of cases of asthma. What are the biologic therapies for asthma? The first one that came to market was Mepolizumab. It's an anti-IgE monoclonal antibody. Then came the anti-IL-5 driven monoclonal antibodies, which include Mepolizumab, Reslizumab, and then the interleukin 5 receptor alpha chain directed monoclonal antibody, Benralizumab. Then came another one that targets the receptor for interleukin 4 and 13 called Dupilumab, and most recently a monoclonal antibody that targets TSLP, which is Tezepelumab. Many patients with severe asthma have an inadequate response to biologic treatment and oral corticosteroids and fail to achieve asthma control despite these biologic therapies. Exacerbation rates in study populations treated with anti-IgE or IL-5 or anti-IL-5 receptor alpha or anti-IL-4 receptor alpha are reduced approximately by 50%. But why only 50%? One potential explanation is the need to reach a broader target. The existing biologics target immunologic pathways that are downstream in a type 2 inflammatory cascade, which may explain why exacerbations are only partly abrogated. Type 2 airway inflammation results from several inflammatory signals in addition to IL-5. For example, FeNO is driven by IL-13 and remains unchanged during anti-IL-5 targeted therapies, despite a observed reduction in eosinophils. Eosinophils, in contrast, may remain unchanged during or increase during anti-IL-4 receptor alpha treatment, despite observed reductions in FeNO. Again, this broad inflammatory response that involves IL-4, 5, and 13 ultimately results in the classic features of exacerbations, which include eosinophilic inflammation, mucus production, bronchospasm, and this is initiated by the release of alarmins. What are alarmins? These include TSLP, thymic stromal lymphopoietin, interleukin 33, and interleukin 25, which are released from the airway epithelium in response to triggers. Let's review our current paradigms and concepts of the immunology of asthma. You can see in this diagram that from going from top to bottom, that there is the interface between the airway lumen and the outside world and it all begins with the airway epithelium, which you can see in pink at the top. In response to antigens, irritants, pollutants, microbes, and viruses, the airway epithelium releases those three alarmins that we saw in the prior slide, TSLP, interleukin 25 and 33, which then engage Th2 cells and ILC2s, innate lymphoid-like cells, to then release other cytokines such as IL-4, 5, and 13 that drive cells such as B cells to isotype switch from IgG to IgE, which IgE binds mast cells, which in turn leads to mediators that are responsible for the features of asthma that are listed at the bottom. Also, in response to these alarmins, for example, there is an effect on Th17 cells, which release interleukin 6 and drive neutrophilic inflammation that is also, as we discussed before, seen in many cases of asthma. The role of TSLP in severe asthma. You will now see a brief 3D animation on this topic.
Severe asthma is a complex disease with multiple triggers, endotypes, and inflammatory pathways all contributing to its heterogeneous pathology. Although recent research in asthma has typically centered on the role of downstream mediators in airway inflammation, it has become clear that the focus should shift where it all starts, at the airway epithelium. The airway epithelium is a common source of inflammation and a central factor in asthma pathology. Epithelial tissue is the first point of contact with various insults such as viruses, allergens, pollutants, smoke, bacteria, and other external stimuli. In response to these insults or triggers, the epithelium releases cytokines such as TSLP, or thymic stromal lymphopoietin, which then initiates multiple downstream pathways. TSLP is a key epithelial cytokine. Its overexpression by the epithelium can contribute to an overactive immune response and asthma-related inflammation that has been associated with increased asthma severity and decreased lung function. Evidence suggests that due to its position at the top of the inflammatory cascade, TSLP can play a key role in allergic inflammation, eosinophilic inflammation, and, potentially, neutrophilic inflammation. This means that regardless of the type of inflammation, TSLP might drive an immune response that overreacts to various epithelial insults or injury, causing inflammation that can lead to continued asthma symptoms and exacerbations. Mepolizumab binds specifically to TSLP, preventing its interaction with the TSLP receptor complex and inhibiting multiple downstream inflammatory pathways.
What is the role of the airway epithelium in asthma? The airway epithelium is the first continuous line of defense against inhaled insults. It has a large surface area, about 100 meters squared, that comes into contact with about 10,000 liters of inhaled air every day. The epithelium is a key source of inflammation and is significantly altered in asthma. Similar to the prior slide, you can see that in response to environmental triggers, the airway epithelium leads to alarmins that then direct antigen-presenting cells to orchestrate an inflammatory response that leads to chronic inflammation in terms of neutrophils, eosinophils, and monocytes, which leads to the features of asthma, which include airway hyperresponsiveness, airway narrowing, and mucus hyperplasia. To address more, what are the roles of the airway epithelium in asthma? One, it acts as a barrier and sensor. Two, it mediates immunity, both innate and adaptive. It induces inflammation through these epithelial cytokine alarmins that activate airway inflammation. And it also drives airway structural changes and airway remodeling. Epithelial alarmins are released again after epithelial damage or immune cell activation, and these activate downstream innate and adaptive immune responses. What are some of the characteristics of these three alarmins? So, interleukin 33 has a large number of cellular targets and can augment type T helper 2 responses. Similarly, TSLP also has a large number of cellular targets, and it drives Th2 responses via dendritic and T cells. Interleukin 25, in contrast, has a smaller number of cellular targets, and it requires IL-4 to drive Th2 responses. TSLP has direct effects on fibroblasts, which may contribute to airway remodeling. Airway mast cells are activated by TSLP and may provide a cycle of TSLP-driven structural changes. TSLP finally stimulates airway smooth muscle cells, which in turn can promote airway inflammation. What are some of the features of asthma that are associated with TSLP? One, asthma severity, reduced lung function, potential airway remodeling, reduced airway response, and exaggerated response to viral infections. TSLP is central to the regulation of type 2 immunity and is also involved in non-type 2 immune responses. TSLP expression is increased in airways of patients with asthma and correlates with Th2 cytokine and chemokine expression and disease severity. TSLP is also involved in neutrophilic inflammation via its effects on Th1 and Th17 cells. So in summary, it is important to distinguish asthma severity from asthma control and to address secondary factors leading to poor asthma control, such as in the case of difficult to treat asthma. There are several subtypes of asthma. These include T2 high, T2 low, and mixed. The airway epithelium plays a critical role in asthma, and epithelial alarmins, again, TSLP, IL-25, and IL-33, epithelial-derived cytokines that act upstream in the inflammatory pathway of asthma. I will now present to you a case of a 57-year-old female with severe oral corticosteroid-dependent asthma. Her asthma started in her 30s when she had episodes of shortness of breath and wheezing that were controlled with high-dose ICS/LABA and albuterol inhalers. She had exacerbations requiring prednisone once every 2 to 3 years. But these exacerbations escalated a year ago, so montelukast and LAMA, long-acting muscarinic antagonists, were added. The addition of these drugs had a weak effect, and within months, prednisone was added for control at a dose of 20 to 30 milligrams per day. She was seen by an ENT who noted on LPR, on exam, no nasal polyps, and placed the patient on a daily proton pump inhibitor. For more of her history, she did not have asthma or allergies as a child. She has never smoked and works at a home health aide. She has no work or home exposures contributory to her asthma symptoms. She lives in a single-family home with hardwood floors and no penance. Again, her current therapy includes ICS/LABA, albuterol inhalers, montelukast, LAMA, and prednisone, and 20 to 30 milligrams per day, and a daily PPI. On physical exam, her vital signs include a blood pressure slightly elevated at 143/67, tachycardic at 109, no fever, respiratory rate 18, full saturation at room air at 100%, and severe obesity at a BMI of 55. Her lungs were clear auscultation with good breath sounds. Cardiac workup was negative, which included an echo and a stress test. GI evaluation was also negative and included an EGD, barium swallow, and a 24 hour pH probe. I will turn it on now to Dr. Chuck.
Thank you, Juan, for that excellent discussion, highlighting the definition of severe asthma, the heterogeneity of disease, and the biology that underlies the severe asthma phenotype that we frequently deal with in clinic, and the current understanding of biologic targets for treatment of this disease. So let's move into a discussion regarding how to choose a biologic and what our current understanding is, and review a little bit about the goals of therapy, but also how in the real world we are currently selecting biologic from the list of options that are available. So we now have recognized that the current goals of asthma management are to improve symptoms and manage comorbidities and maximize lung function and reduce exacerbations, rescue medication, adverse events, and related to treatments, and visits to the ER and admission to the hospital. And it's important to recognize that underlying this list is really the importance of eliminating systemic corticosteroid use. That our goals in many of these situations are related to this because there's many comorbidities that are related to steroid use, including obesity, depression, type 2 diabetes, osteoporosis, increase in cardiovascular events. So when we reduce or eliminate exacerbations and reduce hospitalizations, and we are helping to eliminate corticosteroid use in our patients. This is really one of the key things that biologics have allowed us to do for our patients that we weren't able to do prior to their development very effectively. So here's our current GINA guidelines. You can see the approach to patients who are 12 and older. We still use this stepwise approach to define a patient's severity, with step 1 and 2 patients being mild or intermittent patients who have as needed medication requirements. And then as we move up in severity, we also increase the amount of medication a patient requires to achieve control, or if they remain uncontrolled despite those treatments, we step them up to the next level. So what you can see here is in the step 4 and 5 boxes that these patients are all on medium or high doses of inhaled steroids and an additional controller medication, usually at least a LABA. And these are the patients that were targeted in all of the biologics trials. And these are the patients that we generally target for biologic therapies. When on those step therapies, they aren't adequately controlled. So this really adheres to the ERS ATS definition of severe uncontrolled disease that Juan outlined. In addition, in patients with these step of therapies, step 4 and 5 therapies, if they are also requiring systemic steroids more than 50% of the year, or have 2 or more flares a year, these are the patients that we generally target for biologics, such as the patient that was presented. So let's go back to our patient and look at the biomarkers that she had as part of her phenotyping visit. You can see here that the absolute eosinophil count on prednisone was 214 cells per microliter. This is elevated in this clinical situation, still in the normal range, but we now recognize that patients with levels above 150 cells per microliter are considered eosinophilic, especially if they're on prednisone. IgE level was 185 IUs per ml. This was somewhat elevated, mildly elevated, but as you can see on the next bullet point, immunocap testing for specific aeroallergens in this patient was negative. So this patient has evidence of T2 inflammation, but by eosinophil count and elevated IgE, but no specific allergies. So a non-allergic eosinophilic patient. ANCA level was negative, so screening for Church-Strauss was negative, but recognized that only about 20% of patients in trials for EGPA were actually positive for ANCA. High-resolution CT scan of the chest was normal. There was no air trapping, so does not exclude asthma, of course. And bronchoscopy was done, and this showed abnormalities consistent with asthma, with basement membrane thickening and focal squamous metaplasia, but no evidence of inflammation. And the BAL was negative for eosinophils, not surprising given that this patient was taking prednisone 20 to 30 milligrams at the time of the bronchoscopy. Lung function testing was done, and as you can see, the methacholine challenge test showed a PC20 of 12 mg per ml with some improvement after albuterol. So technically negative, but did show evidence of a slight reversibility. And spirometry showed a low FEV1 and a low FVC with a normal ratio and an exhaled nitric oxide level that was 38 parts per billion with normal DLCO and total lung capacity. So really some evidence of restriction based on spirometry. In this case, it could be pseudo-restriction, which is why the patient has both a low FEV1 and FVC. So if aggressively treated or reversed, you may see that vital capacity improve. So here's a slide that is similar to the slide that Dr. Cont'd showed. You can see here the biologic pathways that we understand are contributing to airway inflammation and asthma, and highlighted on each of the molecules are the biologic therapies that are currently available. You can see in the lower left, the first biologic approved for treatment of asthma, Mepolizumab. You can see the target is IgE for that. You can see over to the right of that, the Registry, Mepolizumab, which were the second drugs approved for the treatment of asthma. These are anti-IL-5 drugs that inhibit the actions of IL-5. Then came Benralizumab, which is the anti-IL-5 receptor drug, and then Dupilumab there, anti-IL-4 receptor alpha, which is the co-receptor for both IL-4 and IL-13. And then up at the top, the most recent addition to the clinic, anti-TSLP, Tezepelumab, which binds to the alarmin TSLP. So here's some of the data that we'll show you related to anti-IL-5 therapies. You can see here Mepolizumab and Registry bind to IL-5 and prevent it from binding to the IL-5 receptor, so inhibiting IL-5's effects. Benralizumab binds to IL-5 receptor, and by doing that, inhibits the ability of IL-5 to bind to its receptor, but also causes apoptosis of the eosinophil, and this is active on cells in the blood as well as cells in the tissue. Here you can see the phase 3 trial, MENSA, that was published in the New England Journal, looking at the effects of Mepolizumab on exacerbation reductions. You can, in severe eosinophilic asthma, those patients with eosinophil counts that were 150 cells per microliter at screening or greater than 300 cells per microliter in the year prior to screening. You could see placebo on the blue line here, and then the treatment with Mepolizumab significantly reducing exacerbation rates at both the IV dose as well as 100 milligrams sub-Q, which is the FDA-approved dose. Here you can see the phase 3 data from Sirocco and Colima, companion phase 3 trials on benralizumab, again showing reductions in exacerbation rates in patients with eosinophil counts that were 300 cells per microliter or above. And then you could see that the effect of the drug is less compared to placebo in those patients with eosinophil counts less than 300 cells per microliter. So really highlighting the value and importance of phenotyping patients and checking eosinophil counts to identify these patients that are most likely to respond to the drug. Then dupilumab, of course, which binds to the IL-4 receptor alpha and prevents signaling of IL-4 and 13 pathways. You can see it's indicated both for patients who are eosinophilic, allergic, high FeNO, or are steroid dependent. And blockade of this, of course, downstream JAK-STAT pathway affects both IgE levels as well as reducing FeNO levels. Here you can see the subgroup analysis of the phase 3 trial Quest that was published in the New England Journal of Medicine. The overall outcome in all comers showed a significant reduction in exacerbation rates. But as you can see by both the eosinophil biomarker as well as the FeNO biomarker, that patients with low levels of eosinophils, less than 150, or FeNO levels less than 25 parts per billion, showed less of a response compared to placebo. So this led to the approval of the drug in the eosinophilic subtype of patient. Our most recent addition to the clinic, tezepelumab, binds to TSLP and blocks it from interacting with its receptor. And because of the nature of TSLP's effects broadly on the inflammatory cascade, it has broad effects of both T2 high as well as T2 low patients. Here you can see data published by Jonathan Korn in the New England Journal of Medicine of the phase 2 data that showed a significant reduction in exacerbation rates compared to placebo at 52 weeks. You can see here 61, 71, and 66% reductions depending on the dose of tezepelumab that was used, with the highest reduction in the FDA-approved dose of tezepelumab, which is 210 milligrams every 4 weeks. This was very exciting because these were some of the strongest reductions in exacerbation rates we had seen in biologic trials. But as you can see on the next slide here, that when you look at the patients by different biomarker cutoffs, you can see that in both high T2 biomarker as well as low T2 biomarker, there were significant reductions in exacerbation rates compared to placebo. And this was unique compared to all the other biologics that had been approved, including dupilumab. You can see that in blood EOs less than 250, FeNO levels less than 24, and non-allergic patients, that there were still significant reductions in exacerbation rates compared to placebo. This held up in the phase 3 trial. You could see that was published by Andrew Menzies-Gow in the New England Journal of Medicine, the Navigator study that I was fortunate to be an author on. You could see the overall reduction there favored tezepelumab compared to placebo, And then again, regardless of the biomarker cutoff used, there was a significant reduction in both high and low biomarker subgroups with the use of tezepelumab. Also very nice to see reduction in biomarker levels for T2 inflammation with the use of tezepelumab. Here you can see from the Navigator study, reductions in blood eosinophil counts happen as quickly as 2 weeks following initiation of the drug and are maintained throughout the year-long study. FeNO levels also responded very rapidly and stayed low for 52 weeks, and IgE levels decreased as well. Pattern of response was somewhat different, slow and steady over the year, but you could see the reductions at 52 weeks. And then also exciting about tezepelumab was this biopsy study published in Lancet Respiratory Medicine called Cascade, where examination of airway biopsies before and after the initiation of tezepelumab showed significant reductions in eosinophils compared to placebo. There was also some reduction in mast cell numbers, you can see here, but this did not reach statistical significance. But again, it's tantalizing that anti-TSLP has broad effects on cell types in asthmatic inflammation. Now, what other therapies are coming down the pike? As we know, more is going to come into the clinic. Here's some data from Steve Kelson from Journal of Allergy and Clinical Immunology on astegolimab, the anti-ST2 biologic. ST2 is the receptor for IL-33, another alarmin that Dr. Cont'd discussed, and that has effects in airway inflammation as well. You can see here similar effects across different biomarker groups in reducing exacerbation rates. Again, really highlighting the importance of these molecules as biologic mediators of both high and low T2 inflammation in asthma and their potential importance as therapeutic targets in the disease. And then here as well, itepekimab, which is an anti-IL-33 antibody, which binds directly to the cytokine as opposed to the receptor. And here you can see as well in this study that was published by Mike Wexler in the New England Journal of Medicine that itepekimab significantly reduced exacerbation rates, but when in addition to dupilumab, did not have any added effect. So where are we and how do we apply this therapies to patients now when we have 6 agents and no head-to-head data? What we do have is a lot of experience, and we have inclusion criteria, and we understand outcomes in these patients by looking at subgroup analyses by biomarkers that I showed you. So this was looked at by a consensus group published in JACI in Practice by Roland Buell. You can see here in those patients who are low T2 that have low blood eos, if their FeNOs are greater than 25 parts per billion and they are allergic, then the consensus was that dupilumab, omalizumab, or anti-TSLP are the therapeutic options for those patients. And if they're non-allergic, dupilumab or anti-TSLP are the preferred agents. And those patients that are low blood EO and low FeNO, you can see on the right-hand side of the screen, that are allergic, they are anti-IgE candidates or anti-TSLP candidates. And if they are low, so low blood EOs, low FeNO, and non-allergic, then the only drug currently approved for that patient population is anti-TSLP. In patients who are eosinophilic, one with eosinophils 150 to 1500, then these individuals have a lot of options for therapeutics. Anti-IL-5 therapies, both soluble IL-5 and the receptor, are options for these patients, as well as anti-TSLP. And if they have high allergies, then they're also candidates for anti-IgE. In these patients who have comorbidities where there's other indications approved for these drugs, then there's a consensus that you should use the drug that's approved for both indications. So anti-IL-4/13 for patients who have severe atopic dermatitis, multiple options for patients with chronic rhinosinusitis with nasal polyposis, since we have multiple drugs approved for that indication as well as severe asthma, and then also patients who are allergic. What about patients who have very high blood EO counts? Well, these patients were excluded from the dupilumab trials, so they're candidates for anti-IL-5 therapies. And those that are systemic steroid dependent, the drugs that have shown the strongest effect for reducing systemic steroid use in those patients are the anti-IL-5 pathway drugs and anti-IL-4/13. So what's been happening in the clinic since the addition of these drugs to our practice? And you can see here in this retrospective analysis of US and European registry data, the evolution of the use of biologics over time. On the left hand, you can see 2015 when Omalizumab and Mepolizumab were available, and then with the addition of Benralizumab to the clinic, Reslizumab and Dupilumab, as you move to 2017, 18, and 19, you can see broad use of all these biologics in the clinic. And this really mirrors our practice here, where we have the key biologics, Omalizumab, Mepolizumab, Benralizumab, and Dupilumab being used in roughly equal quantities across a population of severe uncontrolled asthmatics. This shows the general practice in patients in terms of switching. So if you look at patients who stopped or changed biologics, on the left-hand side of the screen, you can see that somewhere around a year, most patients are either will switch or stop a drug. I think that's generally our experience, that most physicians will treat a patient for 6 months or so before determining if there's an adequate clinical response or whether the patient should be switched to another biologic. On the right-hand side of the screen, you can see the nature of switching. Patients from anti-IgE drug to anti-IL-5 drug, most commonly, and often patients will switch from one anti-IL-5 drug to another, so their initial phenotype will be considered, and they'll be switched to another drug that might work in that same phenotype. And then, of course, smaller percentages switching from anti-IL-5 to anti-IL-4/13 drug, and then occasionally from anti-IL-5s to anti-IgE. So overall, what we see is that about 80% of patients who are started on a biologic continue. So very high rate of adherence to these medications. I think that highlights the strong effects that they have on patients. And about 20% stop, 10% stop altogether, and about 10% switch. So let's go back to our patient as we finish up. You can see here the laboratory data that we discussed. And then what happened was the patient was started on Benralizumab, and this was stopped after about 9 months because the patient did not improve significantly and was still requiring systemic steroids. Dupilumab was started at 300 milligrams every 2 weeks, and the patient improved initially, but then went back on prednisone at the same dose as before. And after about a year, this was in the middle of the pandemic, this drug was discontinued and tezepelumab was started. about 6 months ago. The patient dramatically improved in 2 to 3 months, was able to taper off prednisone and lose 50 pounds. Here you can see the ACT score for this patient over time was low, and then after initiating tezepelumab, improved now to 22. Dr. Cont'd, how would you approach selecting a biologic for this patient?
I think the approach that you outlined in this case presentation is totally reasonable, and I probably would have followed the same approach. I think targeting somebody who's eligible for anti-IL-5 based on the eosinophil levels is absolutely appropriate. Based on a lack of response, the best thing to do is to move forward. I think a different category biologic makes a lot of sense, especially somebody who has an FeNO level at that and is oral corticosteroid dependent. I think both are indications for using an anti-IL-4. And again, based on a lack of response, moving towards an anti-TSLP is perfectly reasonable. But then again, it's a lot of it has to do with a patient preference. Some people like a more less frequent dosage, less frequent administration of the biologic, and they choose the biologic based on that. A lot of it has to do with the possibility of switching over to administration at home, and they're based on that. And a lot of people like the newest drug that's available in the market, and they're so. I guess part of my response has to do with having a discussion with the patient and making choices that are based on a discussion with the patient.
Yeah, I think you're highlighting some really important factors that go into selecting a biologic, and that is not only the biology of the patient and what your understanding of their treatment, but since we have multiple agents available, what the patient's preference is. And that usually requires not only just some practical considerations, but also if the patient can travel into the clinic to receive the medication, and actually some layman's explanation to them about what we'd expect for a response or why we're selecting or suggesting the drug that we're selecting.
Absolutely.
Yeah. So I think we've highlighted a number of important topics related to severe asthma and the use of biologics. That's indicated for patients who are step 4-5, who remain uncontrolled. There are multiple biologics available, and now novel therapies against alarmins, including TSLP and other drugs coming down the pike.
Thank you very much for your attention.
Really great discussion today. Appreciate everyone's attendance and hope it was valuable to everyone who listened.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/TCG860. This activity is supported by an independent educational grant from AstraZeneca LP.